I think we'll go ahead and get started. Good morning, and I think most of you already know me, but I am Lara Dhingra. I'm a research psychologist. I'm a clinical psychologist by training, and my role here in the department has been to develop and implement a program of research, and one focus of that research has been in the area of pain-related disparities. And by disparities, these relate to differences in the adequacy and treatment of pain and access to care for racial and ethnic minority populations, and how to reduce or prevent differences in outcomes of care for these specific populations. So I was very excited and delighted when Dr. Eddy asked me to present this lecture, and in the past, Terry and I have co-presented this together, so I'm also extremely happy that she's here today and hope that she, as well as all of you, will participate in making this as interactive as possible. So, as many of you are well aware, there's a growing need to improve pain assessment strategies and measures in diverse populations who have advanced medical illness. So there's growing data from the literature that factors such as race, ethnicity, culture, which is the specific focus of this particular lecture, gender, socioeconomic status, religious and spiritual beliefs, can all influence how a person appraises their pain, how they interpret their pain, and how they express their pain. This can also affect how we as healthcare providers assess pain. So a better understanding of these specific cultural factors in particular may help us understand how to guide our pain assessment, guide our treatment decision making, and our treatment planning. So I want to point out that as we continue to study and pay attention to potential factors which may relate to cultural differences in pain expression, there are probably more similarities than there are differences among different groups, but specific factors can play a role. And I think hopefully as we discuss this, we'll try to get a sense of how they do affect pain assessment and management within the context of palliative care. So this is a quote from Norma Thomas. Norma Thomas is a social worker who has published and taught in the area of healthcare utilization and social and cultural determinants of healthcare utilization, particularly in African American populations. And she provided a rationale for cultural competency. What do we mean by cultural competence? Why does it matter? She said, when individuals lose control over main aspects of their life due to illness, their basic core beliefs and value systems are critical components of culture to which they can and often do hold. So I thought this provided a nice segue into the utility or the sort of premise behind why cultural competence matters. So I wanted to begin by describing the elements or the core constructs that comprise culturally effective care. How do we define culturally effective care? What does it look like? Next, I want to discuss several theoretical frameworks for cultural competence. And there are two competing frameworks, and we'll kind of review those and the advantages and disadvantages of each of them. Then we'll examine barriers to culturally competent pain assessment and management in palliative care. These potential barriers are factors that may impede pain assessment and management, and we also can talk about facilitators or factors that promote culturally competent pain assessment and management. Typically in the literature, these barriers and facilitators have been grouped according to patient, provider, and system level barriers and facilitators. Following that, we can spend some time talking about specific clinical strategies for culturally relevant pain assessment and management. So I hope that these are potential strategies that you can apply to your own practice with patients, and I'll include some measures and validated tools that have been translated into multiple languages that you already may be familiar with or may just be introduced to that potentially you can incorporate into your practice. Finally, given our very large ethnic Chinese population here in New York City, ethnic Chinese are the largest ethnic subgroup here in New York City. Latinos, Dominicans in particular, are the fastest growing, which is consistent with the U.S. population overall. I wanted to spend a little bit of time focusing on what's been an area of my research most recently on cultural factors for palliative care in ethnic Chinese cancer patients. So let's begin by talking about culturally effective care. This slide shows two of the core elements or constructs that comprise current definitions of culturally effective care. The first component involves cultural sensitivity, and this is defined as an awareness of how culture shapes patients' values, beliefs, and worldviews. So it implies that we as providers have insight towards culture and how it influences both the experience of patients and their families. In addition, this involves understanding potential differences and respecting them. So not only are we aware of culture and its role and its potential influences, but we develop an understanding and a respect towards those who may have cultural views, values, and beliefs that differ from our own. So I think in this definition there's an implicit understanding that we adopt or have or demonstrate behaviors that are non-judgmental towards patients, even when their cultural values differ from our own. And we'll talk more about that, that insight, our own insight towards our own feelings in this matter. The second area involves cultural competence, and this is comprised of the knowledge and skills that are required to obtain positive outcomes in cross-cultural encounters. So do we have the skill set that enables us to understand the experience of different groups and how best to tailor care so that we're able to recognize how patients' values may affect their preferences for care. So this is a conceptual model that was developed by Kemp and colleagues in 2005 that summarizes some of the constructs we just reviewed. On the left of the screen, you can see that one domain involves cultural sensitivity. On the right, a second domain involves cultural competency. So these are the two domains we just reviewed. Cultural sensitivity involves two main elements, an attitude component and a respect component. So this attitude component, in psychology research, we define attitude as perceptions that an individual has that are either positive or negative. So there's a valence there in terms of our feelings that affect our beliefs and perceptions about things. Respect, we talked about respect, that we understand there may be differences among specific cultural groups or individuals, and we adopt a non-judgmental attitude. So that helps foster sensitivity, which has sort of a bidirectional relationship with cultural competence. Cultural competence involves the knowledge and skills, the degree to which we have the capacity to understand how cultural factors may influence patients' pain expression, their preferences for palliative care, and their treatment decision making. So within the area of cultural competency, there have been two frameworks for trying to conceptualize what constitutes it. There's a generic framework for cultural competency and a specific framework for cultural competency. And we'll talk about that in the next few minutes. Both of these things are hypothesized to promote culturally effective care, and culturally effective care has been speculated to mediate the relationship between sensitivity and competency and better patient outcomes.
Before we get off that slide, it strikes me that you could perceive yourself to be culturally competent without being respectful or having, that those two things do not necessarily go together. You could be one or the other or both. But
exactly.
Competence does not necessarily incorporate attitude or respect.
That's a great point. So theoretically, Terry is pointing out to the point that this particular model may assume that competency engenders a degree of sensitivity, which sounds great on paper, but on a pragmatic level, they may in fact be mutually exclusive. So what's nice about models is, on some level, They may be explanatory, but they're not always pragmatic. So that's a great point, and I think it's something that we should probably note when we're trying to operationalize this into practice. So one particular framework for theorizing cultural competency involves a generic framework. And this particular framework posits that a general or core set of knowledge and skills can be applied to any specific patient encounter or community across different cultural groups. So this predisposes that there's a general fund of knowledge that a healthcare provider may have that will be ubiquitous or equally applicable to patients across different situations. The key here is that as long as a provider maintains openness towards other cultures, and that's that non-judgmental attitude, that respect, that attitudinal component, which involves suspending either positive or negative beliefs about the preferences of specific groups, is what promotes better outcomes. So obviously, I think some of you probably already guessed it, there are limitations or potential disadvantages of this particular conceptualization. So a generic knowledge set is often inadequate for developing cultural competency. We know that there are too many differences within ethnic groups, across ethnic groups, and even across individuals of a particular ethnic group or racial group or cultural group to say that one specific or one host of beliefs is adequate. Members of an ethnic group may share the same culture but hold different core beliefs. So I think this points to the fact that it's important to tailor our treatments to specific beliefs, cultures, values among that specific group. So this lends I guess, credibility towards the competing framework for cultural competency, which is the culture-specific framework. And this says that knowledge and skills are best applied to patients and communities from specific cultural backgrounds when this is tailored to their unique characteristics. So you can see it's sort of, in some ways, complementary or the antithesis of the generic framework, that we need to take into account the differences among patients and do research on that, reflect on that in terms of our approach to care. So what are some limitations of this specific approach? Well, certainly the most obvious one is that there's a risk of stereotyping. When individuals understand or apply culture-specific knowledge to all patients from a particular culture, this potentially results in less meaningful and accurate information. So, we often stereotype as a means of taking mental shortcuts to organize vast amounts of information and put those into categories where they can be readily applied, encoded, accessible, and then retrieved when we come across a person, for example, in this context, of a different cultural group. But in fact, we may be making assumptions in the absence of data. So I wanted to now shift and talk a little bit about potential factors that may act as barriers or facilitators to culturally competent pain assessment and management in the context of palliative care. So certainly the way that I've organized this, as I mentioned earlier, is in grouping these in terms of patient-related factors, provider-related factors, and system-related factors. So one very large and important domain that comprises pain assessment are the language and communication issues that arise between providers and patients. Certainly all of you are well aware of this. There is a lot of evidence to suggest that linguistic concordance between a patient and a provider, so the extent to which they both speak the same language, may influence pain ratings and the provision of pain care. So the data shows that even when an interpreter may be used, in fact, when a patient and a provider speak the same language, the pain ratings tend to be more congruent between the two of them than when an interpreter is used. Now, this is in just a couple of studies. Certainly we would need to look at the limitations of this research, but I think it shows that there's at least a trend here that language can and certainly does make a difference. Another factor that I wanted to sort of spend a little bit of time on is the level of understanding of the patient, really in terms of the method in which the questions are being asked. So for example, if we're administering a numeric pain scale from 0 to 10 to patients, the ability of that patient to engage in abstract thinking. Some have said that applying a number to something like pain involves abstract thinking. Patients who tend to be more concretized or more concrete in their thinking, or who may have limited education, may have a very difficult time with that. Numeric literacy is another issue. To what extent do patients, particularly those who may be of lower educational levels, have the ability to put a number, apply a number to something like pain and understand sort of the metrics with which those numbers on a scale relate. So I think these are important considerations in terms of how we explain things and to what extent they're understood by the patient and the tools we use. So, sure.
Before you get off that.
Yeah.
I think numeric literacy has to do with, I think
numeracy.
Interpretation of the world by numbers is sometimes education, but it is also sometimes the way you think about the world. There are certain people, artists, who don't think about the world in numbers, and medicine is all about numbers, and hospitals are all about numbers. So it doesn't just have to be, so I think we need to be cautious that it's just not about people who may not have education.
Right.
It may be about people who interact with the world in a way that has nothing to do with numbers at all.
It's a great point. That's a really great point. So really trying to get a sense of someone's schema or how they might appraise everything from calculating the risk. We use risk a lot in medicine associated with, let's say, a specific outcome or surgical procedure, to just about anything else when you think about it when asked to gauge or put something on a scale. So that's a really great point. So these are two sets of factors that I've sort of listed here that are patient-related and may affect pain assessment. So one set of factors I'm calling socio-contextual, and these involve things like acculturation, stoicism and expressionism, fatalism, the shame or stigma of illness, gender-related norms, caregiving issues, and beliefs about Western medicine, or the degree to which someone might have mistrust of the medical system, either based on prior experience or history. So a second set of factors involves religious or spiritual beliefs, and these are all patient-level factors that we as providers may want to be aware of. So what do we mean by acculturation? Well, acculturation and generational issues relate to studies that have shown that patients who have lower levels of acculturation, so that is their assimilation into mainstream dominant culture, for example, Western culture, if we're using our current context, often are less likely to communicate in English or have the ability to speak English. And that has been shown in several studies to be associated with higher levels of pain, which is very interesting. And those studies usually haven't looked at factors that may account for that. In our own research, we found that patients who had lower levels of acculturation were also more likely to report greater levels of pain. So it's not clear if this is and I'd be curious to see what your thoughts about this are. Why might it be that somebody who has less acculturation, who might be less likely to speak, think, or read in English, would report higher levels of pain? Sure.
Maybe fear that they'll be undertreated because they can't accurately communicate what they're experiencing.
Absolutely. I think that's probably one very large contributing factor. Other thoughts about that? Might it relate to adherence or the use of medications or treatments as prescribed if someone's less likely to be able to read or understand English? Would that in fact mean that they're perhaps not using medications or treatments as prescribed, or that there are family or other cultural beliefs that might be influencing the use of pain treatment or pain management? So these are some of the factors we really need to study more in detail to understand that finding. Certainly Stoicism and Expressionism can relate to different populations, not just among patients who are racial and ethnic minorities, but also to patients who are elderly, or a culture of Stoicism has been found among military personnel as well. So this is characterized by a lack of openness or willingness to express pain or even emotions that are associated with pain, because this might be perceived as weak. Certainly this is becoming more timely given the returning service personnel from Operation Iraqi Freedom and Enduring Freedom. Studies have shown that individuals from Amish cultural groups typically react to pain more stoically. Even children are less likely to react to pain with an emotional response. In terms of fatalism, some patients may believe that pain or even suffering, which is an interesting construct, is a part of having an incurable disease or an advanced disease, and therefore it's futile to try to control it. So certainly that might affect someone's willingness to express pain. Some patients may have, and the research has shown, particularly among those who are ethnic minorities, a fear of distracting the healthcare provider by reporting pain or being viewed as a bad patient if they complain of pain. So certainly beliefs about fatalism, as well as what defines a good patient or what the role of the physician or the healthcare provider can be, are important. The shame and stigma of illness can certainly influence pain expression in certain cultural groups. For example, among some ethnic Chinese, cancer may be considered taboo. It may be considered an inauspicious omen or a punishment from past sins, if one believes in the idea of reincarnation. Certainly, some may have folk or superstitious beliefs that cancer is contagious. Sort of the failure of the body to perform and be healthy can certainly bring much distress to patients and families. So certainly that can affect someone's willingness to disclose pain. As some of you may have encountered, some ethnic Chinese adults we found in our own research may not be told by the physician or their families that they have cancer. And this is in stark contrast to Western views about autonomy and patient empowerment through information. The research shows that when in fact you do disclose the diagnosis and the prognosis to older ethnic Chinese adults with cancer, they report less distress and play a more active role in decision making and demonstrate more adaptive coping in the context of palliative care. So perhaps there's a collusion to protect patients when in fact they may already know, or they may be more equipped to make better decisions and be less distressed, resisting talking about truth and truth-telling in this context. Certainly gender norms are important. Across multiple experimental clinical studies, women have been shown to have lower pain thresholds, are also likely to report lower pain tolerance than men. And there's some really interesting research coming out about that. Certainly tomorrow, if you're able to come to my lecture with Dr. Natkova, we may be able to get into some of the mechanisms there on pain measurement in men and women. Caregiving issues are certainly important. Caregiver burden is an area of research that Dr. Gleischen has studied for many years, and we're only now beginning to understand how caregiver burden, compassion fatigue and other factors that relate to both families and professionals may in fact impede or inhibit the patient from disclosing pain and other symptoms. Certainly beliefs about Western medicine, medical mistrust, can play a large role in people's willingness to express pain if they have a lack of trust in the treatments or the medical system as a whole that may result. Certainly historical experiences, events play a large role here, and we can certainly think of major ones. Within Chinese culture, certainly the Opium Wars, though not directly related to Western medicine, played a big role contextually in the use of opioids as medications, given the history there. So I think we have to think about these things and reflect upon them when we are encountering a patient. They may not be true in terms of what the patient's actual beliefs are, but they certainly warrant an awareness by the provider and potential exploration if they seem relevant. Religious and spiritual beliefs certainly may have a tremendous role on people's preferences for care, the meaning they ascribe to their pain, the cause of their pain, to what extent certain treatments, such as life-sustaining treatment, may be preferred among certain religious groups. So you are all experts on this here and could certainly lend a lot. Terry, I see you nodding.
I'm just thinking
Sure.
that for those who are not going to have access to your talk tomorrow, that the gender issues are very complicated. It's not about, it used to be about lower tolerance and so on and so forth, about us being somehow hysterical women and so on and so forth. And I just think it's important to say that it's much more complicated than the difference in psychology.
No.
Right, Would you just say a word about that?
Oh,
Because
sure,
just
yeah.
for those who,
Yeah, thank you for pointing that out. I mean, there used to be a certain, like Terry said, bias that women might be more likely to have psychogenic pain or be more somatic or prone to hysteria, but there's a lot more complexity. One particular role may be that of hormones and can certainly mediate or moderate pain response. In terms of, I don't think we're quite there with understanding all of the different mechanisms. It isn't, to some extent too, women may be more likely to report pain than men and are maybe more likely to seek treatment for pain too. So there are differences in terms of healthcare utilization that also may affect that as well. So another set of factors relates to provider-related factors, and I've grouped these into both those related to pain and those related to additional issues. So pain-specific factors relate to provider attitudes, beliefs, and their knowledge of pain. So this really relates to their thoughts and feelings, perceptions about pain management, pain treatment, as well as their competency to treat it. As you know, physicians often receive very limited training in and education on pain assessment and treatment in their medical training, and numerous studies have documented that clinicians repeatedly report a lack of knowledge and satisfaction with their pain care skills and ability to provide culturally competent care for what we have in our country, which is an increasingly diverse society. So I want to point out that regardless of race or ethnicity or cultural background, provider attitudes, beliefs, and knowledge, and a lack of competency to effectively assess and manage pain can really contribute to disparities in the quality of pain care. A study by Karen Anderson and colleagues, who's at MD Anderson, showed that over 50% of providers treating low-income minority patients reported that inadequate pain assessment and inadequate staff knowledge were the top barriers to pain management for them. So certainly, even today, this remains a major issue. In terms of additional issues, stereotyped thinking and bias can affect our pain assessment. Studies have shown that provider beliefs about minority patients or patients with specific cultural and religious characteristics can influence how they evaluate these patients. Stereotypes are considered one of the top barriers to pain management. Even providers report this, and they have the potential to lead to inadequate pain assessment. One of the references I've listed here, Young et al., details a case study of a 23-year-old woman with endometriosis who was told by a provider that she was, quote, too young to have intense pain. There may be specific beliefs, for example, that minority patients are more likely to have higher risks for non-adherence or abuse of analgesic medication. Some studies have been really interesting, and they've shown that even when providers are not overtly prejudiced and deny being discriminatory, that these types of stereotypes do in fact unconsciously and subtly affect their behavior. When they've shown patients, asked providers to read different vignettes, and they've varied the race of the patient in those vignettes, it shows that clinical decision-making may be influenced about perceptions of ethnicity and how that ethnicity may affect factors like adherence or the potential for abuse and addiction. So I think this goes very deep, and it's very powerful. In terms of the research, there have been dramatic disparities in the quality of care that have been shown for minority patients' pain. Karen Anderson and Charles Cleland at MD Anderson have shown that patients often underestimate the pain levels of minority patients. Probably most of you are aware of a really well-known study that was conducted by Knox Todd, who used to be here at Beth Israel and colleagues, and they conducted it in emergency rooms and found that patients who had long bone fracture, very painful thing, if they were African American, they were less likely to be prescribed an analgesic for treatment of that pain than if they were Caucasian. So this was published in JAMA. I urge you all to get a copy of this. It's a seminal article, and it shows that we have a lot of work to do, even though it was a number of years ago. Ethnocentrism is the tendency to believe that one's own cultural norms are correct and to evaluate others' beliefs in light of these beliefs. Ethnocentrism applies to every one of them. Most of us tend to believe that our own attitudes and beliefs and behaviors are in fact probably more favorable, and those who have beliefs and values that match our own are probably correct. So when a patient perceives or expresses or reacts to pain in a way that doesn't conform with our own beliefs or expectations, we may consider these behaviors to be inappropriate or even frustrating. So the tendency now is to adapt a perspective of ethno-relativism, which is the fact that we honor and demonstrate ethno-relativity and recognize that cultural beliefs and values, even when they differ from our own, have merit. This really lends us as providers to develop a sense of self-awareness or insight into our own values and beliefs. How many times have we really taken a step back and said, let me examine what I myself am thinking? What are my attitudes? How may my own culture, whether it's the culture of a healthcare provider, the culture of a specific racial or ethnic background that's influencing our own reaction, may that in fact be influencing whether I'm feeling frustrated by the way a patient is reporting pain, or do I in fact have biases that are producing certain feelings in me and unconsciously guiding my practice. So I think it really lends itself to really taking that moment to think about what's engendering the feelings we're having that may be particularly strong towards a certain patient. I think many times we've often said, well, I know if I had this particular disease, or if I was in this situation, I know that I would use that opioid, or I would pursue life-sustaining treatment, or I would not pursue life-sustaining treatment. So these certainly relate to all of you on a very personal level on a daily basis in a professional context. Incongruity or a mismatch between a provider's background and a patient background, which includes language differences, have been shown to be a major factor that can affect the ability to appropriately understand and assess a patient's level of pain. And certainly this can cause misunderstandings and make communication with patients difficult. It can also lead to potential conflict or mistrust. So we certainly need to be aware of both verbal and nonverbal communication when we're interacting with patients. Use qualified medical interpreters whenever possible, and try to promote more optimal communication. I think we all need to take time to have a knowledge, to develop greater knowledge of patients' cultural practices and beliefs. So even doing research and reflecting on particular background of a patient can be really important when you're coming into the clinical arena. I just listed here a few system-related factors, which is a final set of factors that might be impediments to pain assessment. Certainly time constraints, a lack of, I guess, a high patient to provider ratio is related to time constraints. The ability to really take the time, as Terry always says, to assess the issues, get a good history, talk to collateral sources, to families. Certainly structural issues such as a lack of insurance or underinsurance, limited availability of resources due to economics or geographic location of the patient can affect our ability to do a thorough pain assessment, and the access to multi-language pain assessment measures. So fortunately, the advent of multiple pain assessment tools that have been translated and validated in multiple languages addresses one set of these barriers. The Brief Pain Inventory is a tool that you might all be familiar with, and I have a copy of that to share with you. The Wong-Baker FACES scale is another scale that we'll review, and the FLAC, the Face, Legs, Activity, Crying, and Consolability scale. All of these have been normed and validated in different populations, several of them in different, with different language groups, and they have the potential to improve pain assessment and treatment and communication between patients and providers. So this is the Brief Pain Inventory in Chinese. This is a well-validated tool. Most of you know it assesses both pain severity and pain interference. It assesses pain severity by asking patients to rate their pain now, their worst pain, and their average pain in either the last week or the last 24 hours. You can vary the time frame depending on your specific needs. Pain interference asks patients to rate the degree to which pain interferes with various domains of function, such as mood, sleep, general activities, walking, across 7 different domains. And this is a tool that's widely used in research, and it's been translated now, I think, into 50 different languages. Many of them have been validated. This is the Wong-Baker FACES scale. I think most of you are familiar with this. Here, multiple languages are shown. It was originally it was developed for pediatric patients. And it can be used with adults, of course, particularly those who have problems with numeric literacy, as Terry pointed out, or nonverbal. Certainly it is something that we have found in our research with ethnic Chinese populations that patients and providers prefer and find to be more valid. This is the FLAC scale. Given the context of palliative care, I think most of you are probably familiar with this. It's performed by the healthcare provider. It can be used for nonverbal adults who have challenges in communicating pain. It was originally designed for children between the ages of 2 and 7. There are 5 different behavioral categories here, as you can see, and each of these are rated on a scale of 0 to 2 to provide an overall pain score from 0 to 10, which is consistent with the numeric rating scale, such as the one utilized by the Brief Pain Inventory. So I wanted to spend our last few minutes discussing with you clinical strategies that may or may not be useful, and I hope you'll think carefully about this for the provision of culturally relevant pain assessment and management in palliative care. So what are the benefits of utilizing culturally relevant strategies? Well, the provision of culturally relevant care is essentially analogous to and consistent with patient-centered care. An understanding of the specific cultural values and beliefs among certain groups and individuals within that group may promote more effective pain assessment and management. Knowledge and sensitivity can prevent cross-cultural conflicts, patient mistrust, and treatment non-adherence. This is all sort of the theoretical or conceptual basis for why clinically relevant care may be beneficial. So what do the recommendations lead to in terms of providing culturally relevant care? Well, the first is they recommend that all of us conduct a cultural assessment, that we reflect on and research a patient's cultural background prior to the clinical encounter whenever possible, that we assess patients' and families' attitudes, beliefs, and expectations for pain, as well as palliative care. We learn about the structures for disclosure and decision-making. Within the family system, there can often be complex systems for how information is gathered, for how decisions are made, who might be the primary decision maker, whether it's collective, whether it's collaborative among family members, whether it tends to be delegated to one particular individual who's given more autonomy and power. Who is the gatekeeper? We want to identify the preferred language that patients may have and prepare for that by having a medical interpreter. We want to exercise strong communication skills. So what are some tenets of this? Well, Terry, Maddie could probably comment a lot more about this. We want to have demonstrate active listening. Certainly one of the rules of thumb that I was always taught was, you want to listen 7 times more than you speak. And sometimes that can be very difficult when we're rushed, we have limited time, many factors that complicate our assessment and history taking. We want to ask open-ended questions. So instead of eliciting a yes-no answer, can we ask questions that begin with, let's discuss, or can you tell me more about? This can often gather more data, which helps us to help patients in making more informed decisions. We want to allow the patient to respond without interrupting. How many times do we ask a question and then we immediately juxtapose or interject another question before they even get a chance to answer? So certainly these are some basic things that maybe I know myself need to be reminded of often. So one particular model that I've included the reference here for, and I'll make sure you get a copy of these slides, for the provision of culturally relevant care is the LEARN model, and some of you may be familiar with this. LEARN stands for listen, explain, acknowledge, recommend, and negotiate. Listen with sympathy, and I would change this to empathy. Sympathy implies pity. Empathy is the ability to understand or put yourself in the position or viewpoint of another. Listen with empathy and understanding to the patient's perception of the problem. Explain your perceptions of the problem. And then I would add here, elicit from the patient or family member their perceptions. Acknowledge and discuss the differences and similarities between perspectives. So this implies that there may be an internal disconnect or discordance between perspectives, either among patients and families, patients and providers, even among providers. Recommend a treatment plan. Negotiate a mutually agreed on treatment plan. So how do we honor and acknowledge preferences for care and not devalidate these, but then also recommend what we feel are best practices and then reach a mutually agreed on plan. So in the last few minutes, as I see we have just a few more, I would love to share with you some research that I've been doing for the last couple of years here in Chinatown. So as many of you know, China is incredibly diverse in the number of ethnicities. There are over 56 ethnic groups. Han is the dominant ethnic group within China. So this map on the left shows the population of the different ethnic minority groups that are non-Han, and they comprise only 8.6% of the population of China. So incredible diversity within China. So what are some unique cultural considerations for ethnic Chinese patients? And again, these are just some general observations. They are certainly not stereotypes or universally true. There may be concerns that patients underreport pain. We in fact found this was not true, and I'll share with you some data on this. Patients may be unfamiliar with the use of pain scales. They may prefer to use verbal descriptors. We found that in our research. Linguistic differences are common. Patients may be reluctant to share information about their emotions and moods. This is relating directly to Stoicism. We'll talk more about it. First-generation patients, patients who were born overseas, may fear that interview information will be released to government officials. So certainly this engenders a degree of privacy, and how will my information be used that we have to be mindful of. Elderly patients may not be told they have cancer. This relates to disclosure and truth-telling, which we discussed earlier. And they may have a preference for complementary and alternative therapies. So one specific set of factors that are cultural specific in Chinese culture relate to family influences. And these, of course, may be true for non-Chinese patients as well. In Han Chinese culture, again, Han is the predominant ethnic group within China. Family caregivers may play a dominant role in healthcare decisions and treatment. The research shows that family members' beliefs may be the primary determinant of whether a patient decides to use an opioid. Family, in fact, are the gatekeeper for all healthcare decision making. Family concerns about opioid analgesic use, as I just mentioned, have been correlated with inadequate analgesic use in patients. And this research was done by Lin and colleagues in Taiwan, who found that family concerns about opioids were the most robust predictor of whether the patient actually used them. Another set of factors involves Stoicism. Aspects of Chinese culture may lead to conduct that parallels the Stoic tradition. Men in particular may be socialized from childhood not to show emotions publicly, as this may be perceived as a sign of weakness, and this may impede the patient's report of pain and the clinician's ability to assess it. Finally, fatalism, the way I've divided this based on the literature is in terms of religious fatalism as well as cancer-specific fatalism. Religious fatalism is the belief that pain should be endured for spiritual purposes. In Taoism and in certain tenets of Buddhism, there may be a belief that if you can endure pain in this lifetime, you may be free of it in the next lifetime. And if you can experience pain and detach from it and not become emotionally distressed by it, you may undergo tremendous personal growth as well as spiritual growth. Cancer-specific fatalism is the belief that pain is an inevitable part of cancer and attempts to control it are futile. So why bother? You're supposed to have pain. You're supposed to have symptoms. That's part of the cancer experience. Fatalism may influence pain expression, pain meaning, and certainly the desire for treatment. So I conducted a study, this was published recently in The Oncologist, to identify the prevalence of pain in first-generation poor and underserved Chinese immigrants here in New York's Chinatown. So within New York City, we have a very large and diverse Chinese American population. We have a thriving Asian Services Center here, as you know. 27% of the roughly 500,000 Chinese Americans in New York City are recent immigrants, which means they've been in the U.S. for 10 years or less. 42% don't have a high school diploma. 21% are living at or below the federal poverty level. Over 60% have limited English proficiency. Many of these patients may have profound disparities in health outcomes and healthcare access, including pain. So our study showed, and this was a needs assessment, we had many providers that said to us, you will not find that many Chinese patients report pain. What did we find? 57% of 311 cancer patients reported persistent cancer pain for the past 3 months. This is actually a higher rate than what's been documented in non-Chinese patients with cancer pain if you look at some of the outpatient studies in the West. 28%, roughly a third, reported severe pain. This is pain between 7 and 10. So we knew we had a problem in terms of the scope of pain. We asked the question, how much relief do you get from prescription pain medication? As you can see, 28% said none. 18% said a little. So 46%, almost half, reported getting no or little relief from prescription pain medication. Does anyone have any guesses why this may be? If they're using pain medication, why are they reporting such low effectiveness of that medication?
I think something around mistrust or having their own culturally familiar systems that they rely on.
Right. Right, that's a great point. So is it sort of low efficacy beliefs or low confidence in the use of Western pain treatments? Is it that they're relying on their own complementary and alternative therapies for pain? We saw very high prevalence. I'll share a slide with you. Perhaps this relates to adherence, Maddie? Yeah?
Was that,
or what about adequacy of treatment? Perhaps they're being undertreated. Right, we don't know. So that's the focus of our current study.
Did we know that they were taking it as prescribed?
That's what we're doing now.
Oh,
We are measuring that now. And we found that patients really couldn't even tell you what they were taking.
right.
And the labels are supposed to be in Chinese. So we're targeting some of our research on that specific question. Great point. We should do that. We should. And I think when we get a better sense of use, of adherence, we can answer that question more.
When they're questioned, they may lie, yes, I'm taking it because there is like, like culturally afraid of authority.
Yes, such a good point.
Yeah.
Dr. Gleischen found that in fact cancer patients have low rates of adherence through pill count methodology that was done here a few years ago by her and Denise Flynn, who was a social worker fellow.
That's a whole other aspect of research for us, because I think that we do not do enough work helping patients to understand, to adapt emotionally and cognitively to the need to take medication to prevent pain. That's a really, it's a very important emotional integration of
So let's do a study, Terry.
in my spare time, I'd be glad to.
What is the distinction between fatalism and learned helplessness when it comes to pain behaviors?
I see learned helplessness. So the question is, what is the difference between learned helplessness and fatalism? And I guess I see, it's a great question. I see helplessness as a resignation, a passivity, almost giving up. And that's correlated highly with depression, wouldn't you say, Maddie? Whereas fatalism may be sort of a transcendence or a general acceptance that in fact may even infer adaptive coping in some ways with someone's situation.
But I think it would be more correlated with stoicism than necessarily, or like you said, acceptance than helplessness.
The fatalism.
Yeah, they're almost.
Which one would be more amenable for intervention?
Intervention. I would say both. We target empowering confidence. Can you change cultural beliefs? And that's what I've struggled with in the context of this research. What is our goal? Is it to change patients' cultural beliefs? I always say we don't want to change cultural beliefs, but we want to educate them and let them know that they don't have to have uncontrolled pain and other symptoms, that there are options. And someone has said that's changing cultural beliefs. So I leave it to you. 64% in our study reported the receipt of treatments for pain, including 38% who were using opioids. So 38% using opioids, 46% rating those drugs as being not at all or only a little effective. 47% reported non-opioid analgesics, 11% were using herbal medicine. Much of this you can buy in the back of a Chinese newspaper. Many of these medicines may have metals or other toxic components which can be very harmful. So always ask patients whether they're using this. And this is true of mainstream Western culture. You'll see an increasing prevalence and preference for these complementary alternative therapies. 8% were using acupuncture, which is now considered mainstream for pain management. It's no longer alternative. 5% were using Chinese massage. 3% were using chiropractic. 3% were using Reiki or body work, energy healing. 2% were using Qigong for cancer pain. 1% were using Tai Chi, and 1% were using meditation.
What is Qigong?
What's Qigong?
Qigong. Do people know? Are they familiar with Qigong? I believe it's a particular type of kinesthetic or bodily movement, even a martial art to some extent. Correct?
Really slow.
Yes, you'll see people doing it in the
In
park.
Hong Kong, you see
Yeah.
people in the parks in the morning doing.
I don't know the difference between that and Tai Chi though.
Tai Chi and Qigong.
Huh?
Yeah.
Tai Chi versus Qigong. I don't know. I don't know the
I think they're both
difference.
movement.
Yeah.
Tai Chi might, it's my understanding that Qigong is a little bit more, incorporates more of the energy work in Reiki. I think it's like almost like a combination, or it's located in between both of the legs, and I think the way that I understand it is that it is a little bit of a combination of Reiki and Tai Chi, so it has some of the movements of Tai Chi, but it has the energy component or
Yes.
that
Yes.
energy work.
I think you're right. I'll look into that and get back to you. I should know that. So we wanted to do more than study the problem. We wanted to do something about it. So right now we're in the midst of a 5-year study. We're working in 3 different community-based oncology practices that treat large numbers of Chinese patients. We're implementing system-level changes to improve care. I'll show you briefly what these are. We're meeting with oncologists, nurses, and staff who take care of Chinese American patients to help them implement these system-level changes. We're giving them what we call plan, do, study, act cycles, where we say, how about implementing pain screening? Try it on 10 patients. We'll come back next week. What were the problems? What were the facilitators? So best practices for pain and symptom care involve pain screening, early follow-up and identification and treatment of pain, provider education, and referral for specialist level care. So we've had some success in getting all 3 practices to implement pain screening. These are busy oncology practices where they see between 30 and 60 Chinese cancer patients a day. Most of them walk in, they don't have appointments. That's consistent with the culture. Patients are highly distressed, have high rates of acculturative distress, family distress, they have cancer. Often pain is at the lowest level of the clinical agenda. But we found such a high level of pain, so we had to feed that data back. And now we're developing part 2, which is follow-up. So can we get some proportion of patients with poorly controlled symptoms contacted for assessment and treatment? And will they be offered a change of therapy? Dr. Portnoy, Dr. Victor Chang, my wonderful colleague and friend at East Orange VA, is going to do education with our Chinese oncologists and their nursing staff to help them learn about best practices that we use here every day, but often don't get translated just a few blocks down the street. And thanks to help from Terry, Dr. Eddie, Selena Chan, we hope to involve more referral for specialist level palliative care here, so we'll be seeing some of our community-based patients. So right now we've screened 1,200 patients. We asked them if they have frequent or persistent pain. 418, so roughly 1/3, say yes. Of those 418, 215 have cancer that is, pain that is cancer related. The rest have pain that is not cancer related. We found a 35% rate of persistent pain among these 1,200 screenings. 26% have pain due to cancer or cancer treatment. So we presented this at the American Pain Society last year. 92% report other severely distressing symptoms, including sleep disturbance, fatigue, and pain that is severely distressing. So Dr. Portnoy's scale, the Memorial Symptom Assessment Scale, how much does that symptom distress or bother you? You may have it, but is it a problem for you? So we have analyzed data from 112 women and men, and this is preliminary data. 66% are women. The mean age is 56, which is consistent with, it's a little bit younger than what you would think for a cancer population. I don't have the range there. 85% are high school graduates or less. 85% do not have a high school education. 20% have no formal education whatsoever. 74% make $20,000 or less a year. That is total household income. We found that psych distress is consistent with mild psych morbidity. It's comparable to Chinese samples in Hong Kong. Hong Kong Chinese tend to be more educated, more affluent than those in mainland China overall. Fatalistic pain beliefs. Our scores on the Barriers Questionnaire Taiwan Fatalism Subscale developed by Sandy Ward and colleagues up in Wisconsin, our scores were higher than Chinese samples in Taiwan. So this may be mediated or moderated by education, by level of acceptance of cancer diagnosis, we don't know. And I've given you the means here. Our mean was 2.1 versus 1.5. Is it clinically meaningful? We're not sure. Reticence to express pain. So how willing are you to express pain if you have it? Well, the only studies that we've found that have measured this empirically have been in Caucasian elderly. And we find that our scores are similar to Caucasian elderly in terms of willingness to express pain. 70% have worse pain greater than or equal to 4. So pain is a problem. 25% are currently using prescription pain medications. So I'm going to end here. I'm mindful of the time. You've been great to discuss